معلش احنا اخرناكم النهارده ونظرا لهذا التاخير فالتو سبيكرز اللي هيتكلموا من بره فيرتشوالي اتاجلوا ليوم الجمعه و البرزنتيشن في السيشن دي هتبقى الاستاذ الدكتور مجدي ادريس. دكتور مجدي موجود؟ اتفضل يا دكتور مجدي. التايتل بتاع البرزنتيشن بتاع الاستاذ مجدي از ريسك ستراتيفيكيشن ان بالمونري امبوليزم. انا متوقع محاضره متميزه من الاستاذ الدكتور مجدي ادريس، خبره كبيره جدا، long term experiences in the field of pulmonary medicine including pulmonary embolism, interstitial lung disease, pulmonary hypertension. اتفضل يا استاذ الدكتور مجدي.
السلام عليكم ورحمة الله والصلاة والسلام على سيدي رسول الله. Thank you so much for the kind invitation. It's really an honor to be with this elite group of physicians and at this very, very prestigious scientific society. So thank you very much for giving me the privilege to be here with you today. So my task today is to talk about risk stratification in pulmonary embolism. And this is my disclaimer. There is nothing in regard to this lecture. But let me take you centuries ago to the great Hippocrates when he said, in acute disease, coldness of the extremities is a very bad sign. I think Hippocrates was trying to risk stratify, and he was trying to tell us that whenever you have a shock status, then the outcome of those patients is extremely bad. And that's indeed still true when it comes centuries later. So this is our current understanding of the pulmonary embolism. I'm not going to go over the whole really complex cascade, but I would like to draw your attention to main problem, the obstruction from one side and the neurohormonal from the other side. It seems that we in clinical practice, we concentrate on the obstruction. We have a thought that it is the clot that caused all the problem. Real life that this is not the case. Because you know that when the surgeon, for example, do pneumonectomy and they ligate the whole pulmonary artery, nothing happens. When we do right heart cath and we do wedging to the major pulmonary artery, nothing happens. So the clot is important, but the subsequent event, which is the neurohormonal release that lead to bilateral vasoconstriction, is the important part. That will lead to this really sudden rise in the right ventricular afterload, and that will lead to the RV failure. Now, in chronic pulmonary hypertension, we always talk about this basic pulmonary artery right ventricular coupling. That is, the contractility of the right ventricle is really able to overcome the really afterload of the pulmonary artery. As long as this is happening, the patient is fine. But once that coupling become uncoupled, now the right ventricle start struggling to really generate the cardiac output, the problem happen. And when you look at the recent guidelines trying to talk about how do we risk stratify those patients, now the guidelines now talk about three status. We used to call that simple, submassive, massive, and that's now changed to low risk of death, intermediate risk of death, and high risk of death. And I would clearly say that anytime you go and see a pulmonary embolism patient, that should be the first question that you need to answer yourself. What is the likelihood of death of this patient? Can I go and take a coffee and then come and see the patient, or I should go immediately now to see that patient? And this is based on a lot of factors, including symptoms, basically biomarker, RV status, and hemodynamics. And based on that, we can make the best, basically, judgment. Now, if you look at what happened to those patients, we know that this is very important because those patients who have a low risk of death, they have almost zero mortality. And those are the patients who have normal right ventricle, very normal biomarkers, and normal hemodynamics. Those patients can be treated with oral anticoagulant and sent home. You don't need even to really bother about them. On the contrary, you have those patients who are in shock. They are hypotensive, and you can see that the mortality is at least 30%. So 1 out of 3 will die. And if they will die within 24, 48 hours. Most of them will die in the first 2 hours. So you have very limited time to make your decision. And then we have those patients, the bulk of the cases are in between, that we call intermediate risk, really pulmonary embolism. Now let's look at that more carefully. So this is the graph that is very important in any pulmonary embolism lecture, because it just tells us a lot. Tells us that a lot of patients, they have very low risk of mortality, and then the mortality start to increasing until shock status, when the mortality is about 30%. So we know once you get shock, the patient is in trouble. But you can notice that what's happening, that we need to look at those patients. They are not yet in shock. The mortality is not 30%, but you can see that the mortality is increasing. And that's what we call the inflection point, where the mortality starts increasing slowly in those patients. So those are the intermediate risk people, and the guidelines say we need to look at those carefully. So let's look at those as 2 categories. Those who have both abnormal RV imaging and abnormal biomarker, that we call intermediate high risk, and those patients who have one of them, either abnormal imaging or abnormal biomarker, and we call that intermediate low risk of death. Now, this is important because if you look at any study in pulmonary embolism, if the right ventricle is fine, the mortality is good. So clearly the message here, what kills the patient in pulmonary embolism is the right ventricular failure. And that's, if you compare this number here, 0%, with this meta-analysis, when you have RV dysfunction, but not shock, they are still stable, you can see that now the mortality is about 10%. So about 10-fold increase in mortality. So it's very clear that the right ventricle is the most important thing in acute pulmonary embolism. And again, I'm really emphasizing the size of the clot is not the most important things. You can have major PE by CT scan and the patient is fine. You can have small subsegmental clot in the right upper lobe and the patient is dying because of the severe vasoconstriction caused by the neurohormonal really abnormality. So how do we look at the right ventricle? Now the guidelines said look at 2 aspects. Look at the imaging and try to look at the biomarker. Now when you look at the imaging, of course CTPA is very important. It makes the diagnosis of pulmonary embolism very high sensitivity, very high specificity. So it's rule out and rule in the disease. But CT is also important in giving you risk stratification. So whenever the right ventricular diameter is more than left ventricular diameter, that is very bad prognostic sign. And the study showed that once this really ratio became more than 1.5, the mortality is shooting up. So this is very important things. When you look at the CT scan, do not only look at the clot, look at basically prognostic measure as well. What about echo? Echo is very, very important as well to look at that. Number one, it can give you this RV-LV ratio in the 4-chamber view. We can look at what we call the TAPSE scoring. Now, TAPSE is utilized more in chronic pulmonary hypertension, but now there is data that TAPSE is important prognostic marker even in acute pulmonary embolism. And once the TAPSE is less than 1.6 centimeter, the patient is in trouble. So what is TAPSE? TAPSE is the tricuspid annular asystolic excursion. So basically it is the movement of the tricuspid annulus with the RV contraction. You can get that very easily from the echo. How much the really RV, basic tricuspid valve is moving up and down with the RV contraction. Also, echo can look at basically if there is a hypokinesia of the right ventricle. And again, you can see that those who have hypokinesia because of acute ischemia, you can see that the mortality in those patients is extremely high. Now, what about the biomarkers? Now, we know that troponin is extremely important, and it always indicates myocardial injury. And if you look at the odds ratio for those patients who have a positive troponin, they have the odds ratio for death is about 30 times. A need for resuscitation is about 14 times. Inotropic support, mechanical ventilation, and it is an independent predictive of 30 days mortality. So high troponin in acute pulmonary embolism is a problem. What about pro-BNP? I'm not going to go over this complex slide, but it's basically suffices to say that whenever you have normal right ventricle and normal basically pro-BNP, then the mortality is very low. Whenever you have any one of those, abnormal biomarker, abnormal RV, the mortality increase. So troponin and pro-BNP are very important, really prognostic parameter. So whenever we make a diagnosis of really intermediate risk PE, the big question always comes, should we thrombolize or not thrombolize? That's the question, because everybody agree on anticoagulation. So I'm just interested to know your opinion, just like a raise hand, who will thrombolize intermediate risk PE? Okay, very few, okay. Anyone will not thrombolize? Okay, so we have kind of splits. So let's look at the data. So those people who will really thrombolize is based on genuine data, and the data show you this. If you thrombolize basically patients, and you look at the pulmonary vascular resistance, those who are thrombolized, the PVR goes down very, very sharply. In about 1 to 2 hours, PVR is down. While if you give only heparin, it will take you probably 2 weeks to get the PVR significantly down. So this is very important. RV get better faster. And we look at the ejection fraction of the right ventricle because of the drop in the PVR, very clearly that those who were thrombolized, you get significant improvement in the RV cardiac output compared to those patients who were not thrombolized. So that looks like very positive things. But is there any impact on mortality, any impact on survival, that the patient is getting better faster? Does that mean that they will live better, less mortality? And the answer is no. So again, this is meta-analysis or 5 or 6 study. You can see that thrombolize or do not thrombolize, intermediate risk PE, you have no impact on direct mortality. And that's very important. It's been tested a lot of time. Everybody tried to do this. No one can show that there is increased mortality. But let's look at 2 or 3 main studies. So let's look at the PETHOS study. And PETHOS study is trying to look at the fibrinolysis of patients with intermediate risk pulmonary embolism. This was a very interesting study because they tried to answer that question. So they included people who were intermediate risk pulmonary embolism. They have RV dysfunction on echo or CT scan and myocardial injury. So they are intermediate high risk group of patients. Now, the endpoint was, the primary endpoint for that study was, first one is death, or, now remember, or hemodynamic decompromise and escalation of care. And this is very tricky because once the author of really any study put more than one endpoint, then you need to look careful about that study. So the primary endpoint was either death or escalation of care. They also look at the safety, they look at bleeding risk, they look for really hemorrhagic stroke. Now what they found that if you look at what were the primary endpoint, basically positive, the answer is yes. The primary endpoint was really positive, p-value was very significant. So the primary endpoint was positive. But remember that the primary endpoint was 2 components, death and escalation of care. And if you look at the death, there was no difference. So most of this really positive primary endpoint came from escalation of care, that the patient is not deteriorating if you thrombolize them, not improvement in mortality. But of course, when the author reported the study, reported that the study primary endpoint was positive. But we need to look carefully, no death improvement. It was only escalation of care. However, this benefit was counterbalanced by bleeding. And now look at the bleeding, major extracranial bleed, about 6 times higher if you thrombolize those patients. the hemorrhagic stroke was about 10 times higher in those patients, 2% versus 0.2%. So any benefit of the thrombolysis was counterbalanced by major bleeding risk. So another group of people trying to play it smart, they said, can we use smaller dose, what they call safe dose of thrombolysis? Because it seemed that thrombolysis have some benefit, make the patients feel better faster, prevent escalation of care. The problem was bleeding. So what about giving half dose, only 50 milligram, not 100 milligram? And I remember that this 100 milligram came from our colleague from cardiology when they thrombolized people with acute myocardial infarction. So the question came, should we now use half dose, only 50 milligram compared to only anticoagulation? Now the primary endpoint was a drop in the pulmonary hypertension, the sudden improvement in the pulmonary hypertension in those patients, and the recurrence of really PE at 4 weeks. And the secondary endpoint, they look at the mortality, they look at the safety, and hospital stay. Now, let's look at the primary endpoint. Now, definitely the primary endpoint was basically positive. The pulmonary hypertension dropped very significantly faster. And this is well known to really thrombolysis treatment. Now, the important part here, that if you look at basically bleeding, there was no bleeding problem. So that was a win when it comes to the safety issue. No bleeding with the 50 milligram. And they will look at the total mortality plus recurrent pulmonary embolism. That was not kind of borderline significant. But again, that comes from the pulmonary embolism, not from the death. So the MOPET study author, they said, look, now I can use lower dose of TPA and I can get probably quite good outcome, decrease in the pulmonary hypertension, reduce recurrent pulmonary embolism, and there is no safety concern. Now, another study, the last study I'm going to show you is the Seattle 2 study, because this was a different approach. So people said, let's even go better. And the Seattle group, they look at a prospective single-arm, multi-center trial of ultrasonic catheter-directed treatment for people with massive and submassive PE. So what they did, so they look at the patient who had significant pulmonary embolism, massive and submassive, differently diagnosed by CT scan, and they had basically RV-LV ratio more than 1. And what they did, they really went to the interventional radiology, they really put the catheter in, and they injected TPA 1 milligram per hour for 24 hours, if this was only one side. If it was 2 sides, 1 milligram basically per hour for 12 hours each side. So the total dose was always 24 milligram, not 100, not 50, 24 milligram over infusion rate directly in the clot. Now, in the primary endpoint, they look at very interestingly, basically 25% reduction in the RV-LV ratio. This means that basically the RV size get basically smaller. They got at the pressure by echo, the 30% drop in the pressure, and they look at for if there any improvement in the perfusion scan, and what about the bleeding. And this is the endpoint. So really the primary endpoint, the RV recover basically faster. They did very well. The RV significantly improved in size within 24 to 48 hours. When they look at the mean pressure, the systolic pressure by echo, again that dropped significantly quickly, basically very quickly, and maintained that for 48 hours. And the perfusion score by either VQ scan or CTPA was significantly improved. So this was very good result in those patients. Again, there was no problem, 0 bleeding. So now we can go from 100 milligram to 50 milligram, and probably if you have this in your hospital, you should go to the basically 1 milligram per hour interventional radiology. So what the guidelines said after this data, should we thrombolize or not thrombolize? Now the guidelines say this very clearly, do not thrombolize routinely. So that's the guideline. It is really red. Recommendation 3, do not routinely thrombolize. And this is based on the notion that no survival advantage, probably some bleeding risk. And who cares if the patient will improve in 1 day or in 5 days, as long as the mortality is not affected. But remember the word routinely. This means that some people can be thrombolized. So who will make that decision? Nowadays, there is this notion of establishing what we call the pulmonary embolism rapid response team. So what is that PE rapid response team? It is very similar to the cardiac arrest team, basically code in the hospital, the code blue in the hospital when experts come to see the patient. Now, the PERT, PE rapid response team, is now established in North America. Nowadays, it's becoming the standard of care in tertiary care hospital in Saudi Arabia. So what does that mean? That whenever you have a pulmonary embolism, the ER or in the ward, they should call the PERT, basically respiratory fellow, will come and evaluate the patient. If the patient is in intermediate or high risk, will activate the code. And once activating basically the code, so not only one man show, so experts will really meet together from the pulmonary cardiology, radiology, interventional radiology, echo, ICU, hematology, etc., will discuss the case and make the plan. Should we thrombolize? Not thrombolize? Should we take him to the interventional radiology? Should we put him in ECMO? Should we call basically cardiac surgeon? All of that. So let me share with you with really one case. So this is a real case that came to our hospital a few years ago. 68 years old man with ischemic heart disease, diabetes. He came with a chest pain and shortness of breath. When he arrived to the emergency department, his saturation was 76%, heart rate is 120, blood pressure is still maintained. Remember that the definition is systolic less than 90. D-dimer was high, chest X-ray is unremarkable. The patient is referred to the respiratory therapist for oxygen therapy because he was desaturating, and you decide to do urgent CTPA. But it was delayed because at the same time there was basically stroke code. And basically our hospital, once you have stroke code, they have the priority. So everybody goes to the stroke code. So CTPA was not done. It was done later on and showed basically major saddle embolism. So then you call the cardiologist, basically resident came and I did, we cannot do formal echo now, so we're gonna do bedside echo. I said, I'm not sure if the RV is dilated. So called cardiology, they said, we'll see, we'll do that basically tomorrow morning. At 5 a.m., the patient became hypotensive. Then you decide to thrombolize him. You call the pharmacy and the drug was not there. They said, at that time, when the doctor called the pharmacist, they said, the drug is not in this building, we'll bring it from the other building. And the history showed that he had a major abdominal surgery 1 week ago. So what should we do in those patients? So the team at that time, they tried to call the interventional radiology for local therapy. They said, we don't have on-call team. We'll do that first thing in the morning at 9 a.m. At 7 a.m., the patient is basically intubated. They called for cardiac surgery, basically for ECMO. Cardiac surgeon was not convinced. They said it's too late, and the patient arrested 2 hours later. So the question is, what went wrong in this case? What was the problem? What was the twist in this patient? Of course, number one, there was a delay in doing the CTPA because the CT department has the priority of really stroke code over the pulmonary embolism. The echo was not available really on hand. There was no basically on-call, basically echo technician. There was delayed in getting the RTPA. It was not available in that building. There was delay in getting interventional radiology, not on-call time. We cannot do it now. There was delay in providing VA ECMO. And then the end result that the patient actually died. So this is why in really our hospital, we started to establish the PERT. So now we have the pulmonary embolism rapid response team, which means that whenever now we have a patient, we activate the PERT code and then everybody will be active. So everybody will get on his pager or on his cell phone that there is pulmonary embolism. The cardiologist and the pulmonologist should go there immediately. The other team should be on call. Interventional radiology will call his lab to say, be ready, we might have someone. ICU will inform, be careful, somebody is coming. The pharmacist will be informed that get the RTPA ready, we might call you, the cardiac surgeon, etc., etc., etc. So with this we think and we know from data that this should improve the outcome in those patients. It is not one-man show. It is a decision of a group of physicians that will make that decision. And more important, you will have all equipment and resources available for you if you decide to get that. So I'm not sure if you have PERT in Egypt, but if you don't, I would strongly recommend to start this, as it saves life and it is the standard of care. Thank you very much for your attention.
Professor Magdi, thank you very much for your excellent expose. You formulate the subject of pulmonary embolism in 20 minutes,
Thank you.
which is excellent presentation.
Thank you.
Professor Magdi, maybe 40 years ago, when they start to use thrombolytic therapy in the management of pulmonary embolism, they use the medications streptokinase or urokinase intrapulmonary through catheters, as you mentioned.
Right.
And now, in your review, there is another trials to inject the thrombolytic therapy in severe cases intrapulmonary.
Right.
What is your opinion? And at that time, there is no D-dimer. It was defined as fibrin degradation product. It is now the D-dimer.
Right.
So that, and the success of the medications was estimated by the increased level of fibrin degradation product, which is now D-dimer.
Thank you so much. This is a very important question. In my own mind, I think the most important advances in the pulmonary embolism basic management is two things: the CTPA and the echo. So these two modalities have changed our feeling, not only to diagnose, but to risk, basically stratify. I think initially when we used basically streptokinase or urokinase, that we don't use anymore these days, of course there is no head-to-head trial, but the TPA is given over 2 hours and then it's done. And now there is a really escalated program that we can give the whole things in 15 minutes. Now, the streptokinase need infusion over 24 hours. So basically it works slower and slower than basically TPA. And very clearly that we learned from the PERT study that the death in pulmonary embolism, if it's gonna happen, it will happen in the first 48 hours and mainly in the first 2 hours. So any treatment strategy should be started within 2 hours, because maybe it will be too late to start. So I think most people shy away from streptokinase because it is slower, it needs perfusion for 24 hours, most likely to get really antibodies and allergic reaction to it, and you cannot give another dose if you give the first dose. So I think the TPA has overcome all of these obstacles, and this is why we go. And nowadays, the thought is maybe the 100 milligram dose that's used by the cardiologist for acute myocardial infarction is not needed in the pulmonary embolism, because, and that makes sense, because when you give 100 milligram for acute myocardial infarction, what would reach the coronaries is maybe 1 to 2 milligram. While if you give 100 milligram in PE, the whole 100 milligram will go to the lung. So maybe we don't need to really give that high dose. So maybe the 50 milligram will be enough. And nowadays, what we hear from the Seattle study, even 24 milligram can be enough. So now it is much more potent, faster, and probably with a lower dose safer than streptokinase.
Thank you. Thank you very much, Professor Magdi Idris, for this marvelous presentation. And now we move to our next session. May I call Professor Muhammad Ibrahim, Professor Ahmed Aiz, and of course, Professor Muhammad Awad, حضرتك.
عنده بقى لابس كاجوال وحالته صعبه يعني.
خلاص 10